10% improvement in performance. That's what we have to do in 14. Now, there's a lot of ways to do this. Many organizations see this and they quickly start taking out big chunks of the organization. And it works, unfortunately, and that's why other organizations do it. But I know that we can make up most of this, if not all, by focusing on a few very simple things. One, we have patients waiting to see us in our clinics, in the medical center and elsewhere in the organization. We have a real access problem. And I want to thank Jay Sear, Susan Sweet, Demetris Litwin, have really been working hard to improve this access situation and get patients in to see us. We have a volume issue as well as a payer mix issue, and improving access is the best way to fix that. This is going to help us on the revenue side of things. We created a new single access port number, 185 UMass MD. I love the co-branding with my medical school partners. UMass MD. If you want to see one of the medical group physicians, or you want to see one of our partners, our private physicians that are loyal to us, 185 UMass MD. Now you have a single access port to get in. All scripts direct referrals. Our primary care docs now, soon, all of them, some of them now, can refer directly to one of our providers through all scripts at this point. And then we have to have very, very tight referral management. We have that operating margin because of a volume issue and a payer mix issue. Our primary care docs that are in our system especially, but our specialists as well, have to refer into the system. This is going to be key. We have a medical group of faculty members from the medical school that is some of the best in the country. There is very, very few reasons for anybody to have to look for a service outside of the medical group and our loyal private providers. Tight referral management, keep that in mind. You do these things, and there's a lot less pain on the other side for us. Now, we can't provide a bunch of services and not get paid for them. We have had a problem with our revenue cycle, especially at the medical center, Marlborough, Clinton, those tied to Saurian. That is on its way to being fixed. We're looking probably at 1/1/14. We'll be at average benchmarks for the rest of the country in terms of performance. And for the folks that are here in the revenue cycle, you probably don't know how much sleep I've lost over the revenue cycle and how thankful I am for what you have done in the last several months, especially to be collecting the dollars for us. But it's not just about the revenue cycle. It's about our coding and documentation, our third-party payer work and denial management. So we can't provide services and not get paid. We've got to get all those dollars in. And then this other part related to expense management is all about productivity. So people say, well, could we take out a bunch of people working on the floors in terms of cutting staff, and would that help us in terms of the expense line? Yes, but then flow slows down and we get people backed up in the emergency departments. Our number one quality issue across the system, patients backed up, boarding in the emergency department, their mortality skyrockets as they're sitting down in the ED because of flow issues. It's an expense issue because those patients cost more to care for, but it's first and foremost a quality issue. When you have somebody sitting in a hallway in the emergency department, their mortality goes up. And that's mediocrity, and we can't tolerate that in our healthcare system. So we have to work on patient flow. We have to get the patients up. I want to thank the folks on 3 Lakeside, the ICU, that have helped us recently related to the ICU. And I got to do a call out to, is Deb Turner in the room? I don't see, oh. And is it Julia McDonough? So in pediatrics the other day, we had 24 boarders in the emergency department, adults. They were very flexible. We put a nurse out on the peds ward, and they took care of adult patients up there, and it helped alleviate the boarding issue. That kind of dedication, that kind of flexibility, that kind of working together is what's going to make the difference for us moving forward. And then supply chain. For a CFO, the most dangerous thing a physician carries is not a scalpel, it's a pen. I still see it in the emergency department I'm working. People ordering things and drugs that are way beyond what the patient needs, It's a quality issue, it's a cost issue. We have to standardize our care across the system, a single gold standard across the system, and using evidence and consensus-based pathways to deliver the same gold standard across the system in the highest quality, most efficient way. Standardization, and for the physicians in the room, it is not the loss of your autonomy, it is the adoption of excellence. And we demand excellence from everyone in this healthcare system. This, if we work this should say operational excellence. If we work hard enough on this, we can avoid a lot of pain. And you know what that means. We can do this. 5% improvement in performance. That's what we need to be successful.